Hello, everyone, and welcome back to our second session. We had a great first session, and we hope to continue. I'm going to start by introducing my co-moderator, Professor Lilian Cao, who you've heard speak and moderate in the first session. She's the current president of IFSO and the senior past president of IFSO Asia Pacific chapter, and the senior past president of the Obesity Surgical Society of Australia and New Zealand. She's a senior consultant at the Flinders Medical Center and clinical associate professor at the University of South Australia. And she's obviously been involved in training multiple surgeons in bariatric surgery, both nationally and internationally. And I'm so glad to have her here as my co-moderator and co-director of the day.
Thank you, Reem. It is a pleasure. And hello, everyone, and welcome to session 2 of the World Health Digestive Day 2021. It is my privilege to co-moderate this session with Reem. She's the Associate Professor of Medicine at Weill Cornell Medical College and attending physician at the New York Presbyterian Hospital at the Weill Cornell Medical Center. She's also the Director of International Endoscopy with board certifications in gastroenterology and internal medicine in both the United States and the United Kingdom. So it's also my pleasure to welcome our esteemed panelists who have kindly joined us for this interesting session. Firstly, I'd like to welcome Samar Matar from the USA. He's a professor of surgery at Baylor College of Medicine, where he's also the chief of division of metabolic and bariatric surgery. He's the past president of the American Society of Metabolic and Bariatric Surgeons and past president of the Fellowship Council. Welcome, Samar. Next, I'd like to welcome Gerhard Prager from Austria. He's the professor at the Division of General Surgery at the Vienna Medical University in Austria. He's the former president of the Austrian Society for Obesity Surgery, and he's the current president of the European chapter of IFSO. Warm welcome to you, Gerhard. Next, I'd like to introduce Eamon Quigley from the USA, who's the chief of the Division of Gastroenterology and Hepatology at Houston Methodist Hospital, Texas. He's the past president of the American College of Gastroenterology and the World Gastroenterology Organization. Welcome.
Hello, everybody.
Last but not least, I'd like to welcome Kazuo Kasama from Japan. He's the director of the Weight Loss and Metabolic Surgery Center at Yatsusa Medical Cube in Tokyo. He's a clinical professor of Oita University in the School of Medicine and Department of Surgery, and he's the current president of the Asia Pacific chapter of IFSO and the immediate past president of APMBSS. Welcome, Kazuo.
Thank you for having me here.
And thank you. And now I'm going to introduce the speakers for this session. We have Dr. Ken Lo, who's a specialist upper gastrointestinal surgeon with an appointment at St. George's Public and Private Hospital, the Carina Private and Sutherland Public Hospital. He's performed over 3,000 surgeries and advanced laparoscopic surgeries, including primary and revisional bariatric operations. And currently he holds the position as an honorary treasurer of the Obesity Surgery Society of Australia and New Zealand, and is the secretary of IFSO Asian Pacific chapter. Thank you and welcome.
Thank you.
We welcome Dr. Caetano Marcassini. He is from Brazil and has been involved in endoscopy and laparoscopic surgery for many years. He brought the intragastric balloon to Brazil in 1999, and in 2017 he performed an endoscopic sleeve gastroplasty. He's currently active in the area of general surgery and dedicated his time to obesity. Welcome. And following this, we have Professor Christopher Thompson, who is Director of Endoscopy at the Brigham and Women's Hospital, co-director of the Center for Weight Loss Management and Wellness. He's a Director of Advanced Endoscopy Fellowship Program as professor at the Harvard Medical School in Boston. We also have Professor Manuel Romero Gomez from the University of Seville in Spain. He's the chief of the digestive diseases at the Virgen del Rocío University Hospital and the head of the group for translational liver and research in the Institute of Biomedicine of Seville and Spanish Network. He's the leader of Sub-Project 7 for the European project Liver and Digestive, leader of the Litmus Project, and he's the coordinator of the European NAFLD registry funded by ESO. And finally, last but not least, we have Dr. Silvia Lete Ferreira, who is the vice chair of IFSA Integrated Health Committee. She holds a PhD and master's in human nutrition, and she's committed to broadening her investigative work in the field of nutrition related to bariatric surgery. She's a member of the ASMBS, IFSO, Bariatric Brazilian and Metabolic Society, and American Dietitians Association. So welcome. And Ken, if you can launch your first case, thank you.
Welcome to the first case study. My name is Ken Loy. I work in Sydney, St. George Hospital, and I'm a GI and bariatric surgeon. And I'm also current executive treasurer for IFSO APC. I have no conflict of interest regarding of this talk, and I speak for Verisys company as well. The first case today we have is Mrs. J.M., who's 50 years old lady, morbidly obese, BMI 51, weight 122 kilo, height 1.52 meters. She had various comorbidity, metabolic problem, including hypertension, high cholesterol, and she also type 2 diabetes, but also on insulin as well, and had diabetic history of more than 10 years. She also had reflux and a small hiatus hernia on gastroscopy, other disease including sleep apnea and arthritis and polycystic ovary syndrome. She was referred to public bariatric program, and based on decisions by our committee with MDT, we decided to perform Roux-en-Y gastric bypass plus repair hiatus hernia if possible. She lost some weight when we started pre-operative fast for about 2-3 weeks, and her operative weight at the time was 115 kilo. Her blood test before showed iron deficiency anemia with hemoglobin of 110. Her creatinine is normal, 81. Her vitamin B12 is also quite low before surgery. Her liver function test showed mildly deranged AST, ALT, and albumin 34 as well. Her other liver panels, including hepatitis B and C, are negative. We performed preoperative ultrasound, which showed fatty liver with fibrotic changes, and subsequently performed FibroScan, which showed early fibrous changes. Just a word of reminding how we're going to measure it, which could be explained by our gastroenterology colleague in the panel. That I think FibroScan, the fibrosis score is regarding of how much pressure in the liver is measuring, and she's roughly around FibroScan of about 2 to 3. Operation-wise, she had a Roux-en-Y gastric bypass, and due to metabolic problem, we decided to do a long BP limb and a short Roux limb, which bypassed total 1.6 meter of small bowel. Intraoperative finding, as picture has indicated, show fatty liver with some early cirrhotic changes despite operative fast, but some weight loss enabled us to perform the surgery. She has difficulty with intubations as well, and also there was a difficult dissection with hiatus due to the space constraint and intra-abdominal access. The left lobe of the liver was quite solid and was difficult to retract with the nascence, which obscured some of the view of the hiatus. Nonetheless, we managed to perform hiatus hernia repair and the bypass successfully. There was some oozing from staple line. The stomach seems to be quite thick as well, but it was stopped by oversewing and also the buttressing as well with seam guard. Wedge liver biopsy performed for diagnostic purpose and comparison for the future as well. Her operations, the postoperative, in fact, was quite unremarkable, and she was discharged in day 4. And on 6-week follow-up, she already showed improvement in her liver function test, and she already lost some weight down to about 105 kilo. She's off oral diabetic medication and still on some insulin as well. And her wedge liver biopsy shows significant fatty liver with some early cirrhotic changes. So 6 months follow-up, her liver function test is nearly normalized, and her weight down to about 88 kilo, and repeat liver ultrasound show marked improvement of liver steatosis, and so as the results of the repeat FibroScan as well. So I guess the question will be open to the panel in terms of our esteemed gastroenterologist colleagues regarding of what sort of investigation if we encounter these cases with fatty liver, and what sort of follow-up, probably more traditional, such suggestive, and also a surgical colleague in terms of whether there is any role of different type of operations applied to this case, and also a nutritionist, and see if 2 weeks of multi fast is enough or not, and also our physicians as well in terms of managing the comorbidity. I'll open this discussion to the panel, and hopefully we can have some insight regarding of how to manage this type of patients. Thank you very much.
Thank you, Ken. And I'm now going to hand over to Lillian to launch the poll.
All right, we have a poll for the attendees. If you could use the dashboard on the right of your screen to answer this poll question, which operation do you think is the best for the treatment of fatty liver disease? There are 5 options here. We'll ask you to choose. While the audience is making up their minds of which is the best treatment, Ken, what is your operation of choice for fatty liver disease?
Look, I think whatever I'm speaking is probably not going to be right. I would defer the answer to my esteemed colleague, but I guess giving the experience from the last sessions, I think it's really opened our eyes when we are collecting our data regarding of obesity as a disease, comparing to COVID even, because COVID disease is only hopefully short term, but this is a ongoing things that is going to consume ourselves. And I think it doesn't matter about operation like Rahul. I think the most important things is when to operate and how we're going to operate without causing long-term or short-term problem. I suspect traditionally Roux-en-Y gastric bypass is what we're trying to do for metabolic disease, but a lot of the other surgical options has opened up the doors on potentially more powerful interventions, according to my surgical colleague. But I guess with power come responsibility, and I think there will be more nutritional issue that we may encounter as well. So I guess that's why we are here for. So I'd rather listen to our expert instead.
All right, before we do that, let's see what the attendees say. Have we got the answers to the poll? We should have any moment now the answers.
Before the answer, I guess I have to throw in a little bit of our Asian Pacific things. I think as you've seen, there's going to be a lot of patients that we have to deal with. And I think we got to plan for the futures, and our criteria, according to Kasama's and all of us looking at our Asian, is slightly different than Caucasians, but we can draw on their experience and see what happened.
Well, looking at the poll, 45% of the attendees believe that the Roux-en-Y gastric bypass is the best treatment for fatty liver disease. So I think we will ask the opinion from our speakers. So I'm going to start off by asking the bariatric surgeon to tell us about this presentation. So I'm going to invite Professor Citano Marcassini for his presentation and his comments.
Yes. Hello, guys. I have a presentation recorded, but the thing is about when doing the surgery, this is a good question. And what surgery depends on basically on what the liver looks like during the surgery, and the biopsy and the pre-op exams will show us. So I think we can show my recording lecture, please. Could we start?
Hello, guys. My name is Caetano Marquezini. I'm a Brazilian surgeon and been doing bariatric surgery for the last 27 years. These are my disclosures. I guarantee any of them will interfere in my lecture. Well, first things first. This is angulation, something I've been doing for the last 20 years. And this 45 angle position modifies consistently the fat and visceral arrangement inside the abdomen, improves the visual angle of the optics, and shortens the distance between the trocar entrance and the camera and the hiatus. Liver retractors are very important during the laparoscopic procedures and usually requires an additional trocar and subxiphoid incision, increasing risk of wound complications and postoperative pain. And the use of traditional mechanical liver retractors had been associated with transient increase in liver transaminases and risk of iatrogenic liver injury. And there are a lot of proposals published. I advise a lot of surgeons to take a look at these papers. In patients undergoing surgery, the prevalence of an FLD is 62%. 1/3 of these patients already have fibrosis. 9 to 20% will progress to cirrhosis. Cirrhosis will be diagnosed incidentally in 4% of surgeries. Bariatric surgery impacts on NFLD in 88% of improvement and leads to 30% of improvement in fibrosis. Gold standard diagnosis is liver biopsy, which is important to calculate an LFD activity score. And interestingly, there was no statistical difference in improvement after sleeve gastrectomy and Roux-en-Y gastric bypass. But we do know that surgeons usually favor sleeve gastrectomy over Roux-en-Y gastric bypass. And this is because there's a potential risk of hepatic decompensation after malabsorptive procedures, a difficulty access of the bypass stomach and bile duct, and the altered anatomy with Roux-en-Y gastric bypass may make future liver transplantation more difficult. The biggest hindrance to preoperative counseling of patients about the risk of the surgery is that the majority of cases of cirrhosis are diagnosed incidentally during the surgery by visual inspection of a nodular liver. Routine intraoperative liver biopsy should be offered to all patients undergoing surgery. Liver stiffness measurement can be reliably and predict the presence of advanced fibrosis preoperatively with a sensitivity of 80% and specificity of 85%. Early postoperative liver decompensation may happen in 7% of the patients, which should be managed conservatively. And Roux-en-Y gastric bypass should not be a contraindication, being reserved for situations where sleeve gastrectomy is not possible as Barrett's esophagus or severe GERD. In cirrhotic patients, portal hypertension is a relative contraindication of the surgery. And the surgery may ameliorate comorbidities as type 2 diabetes, hypertension, dyslipidemia, but will probably not show any improvement in cirrhotic liver fibrosis. In these patients with a compensating disease, the mortality is 0.9%, but it can increase to 17% in patients with decompensated cirrhosis. There's a limited data on outcomes on bariatric surgery in cirrhotic patients, but in cases with advanced liver disease and severe portal hypertension, it has been advised to do the TIPS procedure prior to the surgery. And finally, patients with ultrasound-proven steatosis and ALT level above 53 should undergo intraoperative liver biopsy because there's a high probability of NASH. Thank you very much. These are my considerations, and I will be here for you guys to discuss and talk about what I have stated. Thank you very much.
Thank you, Caetano. I think we'll move on. I'm going to invite Chris Thompson to give his views as an endoscopist. Thank you, Chris.
I'm Dr. Christopher Thompson from Boston, and I've been asked to speak on the treatment of NAFLD and NASH from the endoscopic perspective. Here are my disclosures. To refresh our memories, fibrosis stage is the strongest predictor of liver-related outcomes The mainstay of treatment of NASH is weight loss, with 7% total weight loss being associated with improvement of steatosis and inflammation, and 10% total weight loss required for regression of fibrosis. So the main questions that need to be answered are, can EBMTs achieve a 7 to 10% total weight loss, and is there any evidence for improvement in liver inflammation or fibrosis with these procedures? EBMTs can be broadly classified into two categories: gastric devices such as balloons, suturing platforms, and aspiration therapy, which primarily focus on weight loss, and small bowel devices such as sleeves and duodenal and mucosal resurfacing, and anastomotic devices which have more direct metabolic effects. We will start with intragastric balloons, and there's several types. There are fluid-filled balloons, there's gas-filled balloons, there's adjustable balloons, and procedureless balloons as well. They all have fairly similar weight loss outcomes, so we'll focus on fluid-filled balloons and a meta-analysis of 17 studies in over 1,600 patients that showed a total weight loss of 11% at 12 months. This was really across all relevant BMIs. This was a case report from our group looking at a 29-year-old female with Down syndrome and various serious medical conditions. She was 181 pounds, 4 foot 10 inches tall, and a BMI of 37.8 with NASH. And the initial liver biopsy is seen here with grade 2 steatohepatitis and stage 1 fibrosis. She underwent a 6-month balloon placement, and at removal, her weight was now 110 pounds with a percent total weight loss of 39.2 and a BMI of 23. And the EUS guided liver biopsy performed at the time of balloon removal was seen here with a complete resolution of steatohepatitis and no significant fibrosis. We also have a prospective series of 21 patients looking at early stage liver fibrosis and intragastric balloon treatment. You can see at 6 months when the balloon was removed, there was a 11.7% total weight loss. And here are all of our liver outcomes. There's a 3-point median decrease in NAS. Fibrosis improved by 1.17 stages. MRE detected fibrosis improved by 1.5 stages. And it was a quite encouraging study. However, percent total body weight loss did not seem to correlate with reduction in NAS or fibrosis. Moving on to gastric remodeling and endoscopic sleeve gastroplasty. And you can see here we're trying to really recreate a gastric imbrication procedure endoluminally with a series of running and interrupted stitches. So here's a meta-analysis looking at 8 studies in over 1,700 patients, which shows a 16.5% total weight loss at 1 year and a 2.2% adverse event rate. What about metabolic outcomes? We have a prospective registry from Reem Sharaya's group looking at 118 patients, and they all underwent ESG for NAFLD. Main outcomes here are hepatic steatosis index and NAFLD fibrosis score. In 2 years, we have a 15.5% total weight loss, and you can see the HSI score decreased by 4 points per year, and the NAFLD fibrosis score decreased by 0.3 points per year. So very encouraging. And here we have 24 patients showing an improvement in risk of hepatic fibrosis, decrease from an F3-4 or indeterminate down to a F0, F2, and only 1% of patients experiencing an increase in that risk. Duodenal and mucosal resurfacing also shows some promising results in a multi-center single-arm study of 47 patients, which showed improvement in HbA1c, fasting blood glucose, ALT, and AST, but very interestingly, they showed a 30% lowering of relative fat and a 6% reduction of absolute fat on MR hepatic fat. And finally, we have a meta-analysis looking at all EBMTs and their effect on metabolic comorbidities. 18 studies, over 800 patients, 14.5% total weight loss at 6 months. And you can see here the primary outcome is liver fibrosis, 4 studies, 162 patients. And the fibrosis was reduced. Here you see the standard mean difference by 0.7. And the secondary outcomes, including ALT and histologic NAFLD activity score, were all significantly improved as well, although the grade was low to very low for quality of evidence. In conclusion, EBMTs do achieve 7 to 10% total weight loss, and early evidence suggests that they may offer a promising alternative for the treatment of NAFLD and NASH. And I believe combination therapies and personalized treatment programs are now the keys to future success. Thank you.
Thank you, Chris. I think we'll move on. We'll hear from the hepatologists. I'm going to invite Dr. Manuel Gomez to give his comments. Thank you, Manuel.
Hello, everybody. It's a great pleasure for me to be part of this World Digestive Health Day, and thank Professor Macedo for inviting me to this very interesting panel. Today we are discussing the case by Professor Loy, and I'm giving my opinion as hepatologist in this patient with morbid obesity and NAFLD. This is my disclosures. And our female, in summary, Mrs. J.M. is female, 50 years old with comorbidities, including diabetes, arterial hypertension, hyperlipidemia, sleep apnea, and because with morbid obesity, 53 kilo per meter square as body mass index. That means morbid obesity. Our patient showed a quiet FibroScan with 249 decibelius per meter in the cap. That means in the limit of steatosis, but in the ultrasonography, you can see how the liver is hyperechogenic in comparison with the kidney. And on the other side, FibroScan was 6.8 kilopascal. That means it's a quite relaxed FibroScan, usually associated with non-advanced fibrosis because lower than 8 kilopascal. But it was a surprise when we calculate the epimetriosis score and was 0.84. That means highly risk of advanced fibrosis, and FIB-4 was 3.19, also linked to advanced fibrosis. Is Mrs. J.M. suffering from an NAFLD-associated advanced fibrosis with this FibroScan and this non-invasive method? I think so. In this study by Professor Ampuero, demonstrate how the interpretation of the kilopascal of the FibroScan depends on the metabolic alteration in the liver. When the epimetriosis score is higher than 0.47, a FibroScan lower than 14.3 kilopascals or a FibroScan higher than 6.2 kilopascal demonstrate a risk of that significant fibrosis in approximately 3/4 of the patient, advanced fibrosis F3, F4 in a half of them, and cirrhosis in 8 to 10%. That means our patient seems to be at risk of advanced fibrosis. And please, surgeon, do not forget a liver biopsy during the surgery if doing bariatric surgery. We need to keep in mind what can we do in this patient with NAFLD at risk of advanced fibrosis and morbid obesity. The key point is try to promote weight loss. If our patient lose 10% of the body weight, we can improve steatosis 100%, promote fibrosis regression 80%, and NASH resolution 90%. That means that in the 10% of patients undergoing this lifestyle intervention, we achieve a weight loss of 10%. That means 90% fail to reach this goal. This is the main reason by which we need to move from the diet and physical activity to the use of drugs. In the drugs, we can use semaglutide, naltrexone, bupropion, or orlistat. This drug able to promote weight loss when we analyze what is happening in the liver in the second liver biopsy at 24, 36, or 48, or 52 weeks, irrespectively of lifestyle intervention versus, for example, orlistat. The improvement in the NASH score, steatosis, ballooning, and lobular inflammation was comparable and quite similar. Semaglutide is a GLP-1 agonist able to promote improvement in the liver. In this clinical trial published in New England last year, semaglutide in the high dose demonstrated that NASH resolution in 60% of the patients is a very high rate, but also the semaglutide high dose was linked to body weight reduction of 12.5%. That means that we can be absolutely confident that this drug is able to promote weight loss, and this weight loss was associated with improvement in the liver, in with steatohepatitis resolution, and also with the rest of the parameters. Just in our patient, we should confirm advanced fibrosis in every patient. We need to implement lifestyle intervention. It doesn't work drug therapy. It doesn't work endoscopy and bariatric surgery, because we need to promote weight loss. Semaglutide therapy emerged as a first-line therapy to promote weight loss in patients with not only a risk of advanced fibrosis. This is my part, and now the patient require more advanced therapy, including endoscopy and bariatric surgery. Thank you for your attention. Many thanks to my team in Virgen del Rocío University Hospital, the Department of Disease, and also the Celiber Group in the Institute of Biomedicine of Seville. Thank you very much for your attention.
Thank you very much. And I'd like to now welcome Sylvia to talk about the nutritional aspect of this case.
I would like to thank IFZO and WGO for the invitation. I'm glad to be here, and I'm going to make some comments about Dr. Kinloy's presentation about a patient with non-alcoholic fatty liver disease. I have nothing to disclose. And as we know, non-alcoholic fatty liver disease is the most prevalent form of chronic liver disease in the world. It affects near 15 to 35% of global population, and it is more prevalent among patients seeking bariatric surgery. We also know that a modest weight loss, near 5 to 10%, is known to decrease intra and postoperative complications, such as hypertensive crisis, diabetes, thromboembolism, sleep apnea, and principally hepatomegaly. And we know that decreasing the liver size, it may contribute to a reduction of surgery time. This chart we can see, it is a randomized trial conducted by our team, and we saw that patients that had presented weight loss before surgery, they presented also a reduction in surgery time. So when we talk about weight loss before surgery, most of the time we use a very low calorie diet that is an energy restriction that goes up to 800 calories per day. Dr. Kinloy used the OptiFast, that is a commercial brand of a liquid, very low calorie diet. We know that these diets, when they are used in an adequate way, with an adequate amount of protein, carbohydrates, vitamins, and minerals, they will have patients to present a rapid weight loss. They will decrease visceral fat, they will present reduction of liver size, and they will keep their vital healing capacity with just few side effects. Dr. Kim and his team used this diet for 2 weeks, and the patient presented a good weight loss, near 5%. She presented the 2 nutrition deficiencies. They were treated before surgery. Despite the good weight loss that the patient presented before surgery, during the surgery, they saw that she had enlarged liver. And it happened probably due to the advanced stage of cirrhosis that she presented. However, with 6 months, the patient presented a good amount of weight loss. She had lost 27 kilograms, and she have shown an improvement in the degree of fibrosis, showing that the non-alcoholic fatty liver disease was treated with the adequate amount of weight loss that she presented after surgery. And some recent guidelines, they have shown that even when the patient presents some histological manifestations of liver injury, they can take advantage from the bariatric surgery, and they can get better from their fibrosis with the weight loss, using bariatric surgery as a tool for weight loss. I would like to highlight 3 important points as a conclusion. First, that there was a concern about weight loss before surgery. Dr. Loy's patients that present the BMI higher than 50. This population, they need to lose a little bit of weight because it will contribute to the decrease of surgery time. So it is important to highlight that losing weight before surgery is an important treatment. Second, there was a concern about nutritional screening. There was this concern and the patient was treated. And it is important to highlight that this population, they present at least one nutritional deficiency before surgery. So I was happy that Dr. Kinloy and his team had this treatment before surgery. And third, that bariatric surgery is, and in this case was effective in treating non-alcoholic fatty liver disease. Thank you.
Thank you very much, Dr. Sylvia Ferreira. And now, before we start our discussion with our esteemed panel and speakers, we'd like to relaunch the poll that you heard at the beginning of session 2. Many of our audience members have changed their mind. So the question was, which operation do you think is the best for the treatment of fatty liver disease? And the answers are sleeve gastrectomy, Roux-en-Y gastric bypass, single anastomosis gastric bypass, single anastomosis duodenal bypass, and the endoscopic sleeve gastroplasty. Just to be controversial, Samer, I might ask you as the first question while we're waiting for the poll to launch and answer. Do you think there's any one right answer in this, or is it just weight loss?
Well, the right answer is to do what's right for the patient, obviously. So you need to study your patient carefully, know what their comorbidities are, and whatever other conditions they might have. I was a little surprised, and this is no criticism of my friend, Dr. Loy, but in a patient who has a history of anemia and who has arthritis, who might be requiring NSAIDs, who knows, might be smoking, I would favor a sleeve gastrectomy, especially in patients who have liver disease, because there's always the possibility that they may need a liver transplant in the future, and you want to maintain that endoscopic access to their biliary system. But the only right answer I can say is to do what's right for that particular patient.
I agree. I feel like a lot of patients come in with the preconceived idea of what they want, and here are the answers. Do you want to comment on these, sort of the before and after?
So we can see here a small shift of respondents from gastric bypass towards the sleeve. I think maybe based on understanding the progression of fatty liver disease and that it could lead to liver failure or liver transplant. And some of these patients are very ill, especially if they're very heavy. So I can see the sleeve gastrectomy as an operation that might result in resolution of comorbidities that are equivalent to a large degree with Roux-en-Y gastric bypass. That's what I see here. And it's interesting that also Dr. Thompson's lecture has influenced the respondents. As you can see, there's been a rise in the number of respondents advocating endoscopic therapy.
Perhaps I can sort of echo on Samai. I agree. It was actually a really struggle on which operation we decide to do and tossing around all the risk factors. But yeah, we don't have the crystal ball. We try to do what the best for the patients, and essentially weight loss will be the best. But procedure-wise, it is hard to choose. And I think there'll be a different answer for if we ask everyone, I think.
Absolutely.
Reem, Lillian, can I ask a question?
Definitely.
absolutely.
Sure. I just, first of all, my disclosure is that I'm not a hepatologist and I'm not directly involved in obesity, but I'm very honored to be here. But just listening to the wonderful case that was presented, I had a couple of questions. Based on our previous session when we spoke about cancer and the fact that this patient had iron deficiency anemia, preoperatively, I just wondered if consideration was given to upper endoscopy and perhaps colonoscopy before proceeding to surgery because of the risks. And the other question I had is in terms of the liver disease, how far you would go in terms of assessing for portal hypertension, given that you were also going to perform anti-reflux surgery, and whether, for example, you would do endoscopy looking for varices.
I think we did do gastroscopy, and colonoscopy has been excluded in terms of gastric colon cancer, etc. And I guess partly to assess for the reflux and Barrett's and hiatus hernia, and that's why we decided also to repair it, because there are studies that pointed out even despite Roux-en-Y gastric bypass seems to be the treatment for reflux surgery, you still have to attend to hiatus if possible. And the liver disease do increase the difficulties of accessing the hiatus due to space constraint, but we managed to repair that, and the reflux was moderately or markedly better together with the weight loss as well. I guess I shouldn't speak, I think I speak too much, and I should leave some of the space for my esteemed panel to comment on that.
I'd like to ask a question to our other surgeon in the panel. Gerhard Prager, what is your preferred operation?
I think there is no deep preferred operation. I think all these operations that lead to markedly weight loss will also improve NAFLD. NASH improvement is, of course, much more difficult to achieve. But I just want to mention a word of caution. If we exclude larger amounts of small bowel, there might be, let's call it, too much of a good thing. I give an example. When we had a look at our one anastomosis gastric bypass series, excluding at least 1.5 meter, we see in the first year an transient elevation of liver enzymes, which comes after 1 year to normal. But if you go further and exclude even more, you see also, or you can see, a deterioration of the liver function. This means we should be cautious to exclude bigger amounts of small bowel in patients with advanced stages of fibrosis. Saying that, I fully agree that sleeve gastrectomy and Roux-en-Y gastric bypass with a rather short BP limb are the procedures of choice in patients with advanced liver fibrosis. For those with even cirrhosis, I just want to mention that doing the sleeve gastrectomy, you change the portal blood flow, and this might contribute to an elevated percentage of portal vein thrombosis in patients with sleeve gastrectomy, just to give you a little bit food for the brain.
And to add to that, Dr. Quigley's question, if we get referred patients who have an established diagnosis of cirrhosis, then we typically do look for portal hypertension, because that is a very high risk factor. Patients can essentially exsanguinate on the table. So we do a CT scan, or we do interventional radiology will help us out. And if they do have portal hypertension, then we might apply TIPS, a shunt, to try and reduce their overall mean gradient. This has its own side effects, of course. These are a very high risk category of patients that we treat very carefully and optimize very carefully before considering surgery. But after all, surgery is their only resort, because that's the only way they're going to get a liver transplantation.
I just want to mention that it is very difficult to identify preoperatively those patients with very advanced NASH. FibroScan in our hands was not especially successful in the morbidly obese patients, although we were using the X-large probe. So this is still something we are struggling with, at least in our institution.
I agree.
One thing we do in our institution is a very thorough GI evaluation, obviously even for the surgical patients, but Something that's very useful is endoscopic ultrasound to look at the liver, but then also to do liver biopsies and direct portal pressure measurements. It's minimally invasive, and it's really a great way to assess risk in these patients.
Yes, to add a comment, I would like to highlight that in cirrhotic patient or in patient with NASH and advanced fibrosis, the main aim, the goal is to lose 10% of body weight. That means we need to be conservative when selecting the method to achieve this goal, and we don't need to lose many kilos. No? And it could be very important because we can balance both the risk and the benefit when managing this patient, in which I looking from the liver, no, as a liver-centric point of view. I'm just concerned about that. And just adding a comment to a previous discussion about how can we consider obesity, no, if a disease or a symptom. From my point of view, obesity is just a condition. It's like alcoholism. And this is the key point we need to address, thinking separately. We have two problems, obesity and the liver disease. And separately, we need to address it in different manners.
So if I may, I have a question I've been meaning to ask you, Dr. Gomez. I agree that reaching 10% weight loss is very beneficial for these patients. It reverses a lot of the problems of the liver. The problem is, though, maintaining that weight loss. You know, I have yet to see a paper that has a long-term effect of lifestyle. And medications work, like your GLP-1 agonists, but they're expensive, and the patient would have to take them for the rest of their lives. As for endoscopy too, many of the procedures tend to be temporary, whether it's balloons or sleeves. And so, you know, what are we left with that has a long-term beneficial effect? And frankly, I am biased because I'm a surgeon, but I think the truth is that for now, surgery is the most effective long-term therapy for these patients.
I fully agree. This is the most difficult challenge at this time. How can we address that? Because regain is very common. More than a half of patients in very short period of time, at 5 years, is very common. This is an option to promote endoscopy or bariatric surgery, because the patient need some help beyond the lifestyle intervention, even beyond the drugs. But we need to try to develop a multidisciplinary approach, trying to have, for example, to have the liver recovery in the hospital, as we can recover the heart of the kidney or the lung. I think we need to work together with nutritionists for sure, with the surgeon, hepatologists, and all of us trying to improve the health of the people. That for sure is strongly related with weight loss, but we need to promote weight loss and to keep. And just a major problem that I think we have in clinical practice now is the management of obesity pre-transplant patient. Cirrhotic patient with morbid obesity that require a liver transplantation. What are we doing? And at this time, we can start a therapy in a very short period of time, 3 to 6 months. For example, a patient with liver function okay and a liver cancer, we can try to promote weight loss in 3 to 6 months. But for sure, we need to keep in mind that after the transplant, we need to keep the patient in this weight, and this
or else they lose their transplant.
For sure, this is the same problem that we need to address. Is how are we prolonging over the time all our activity to keep the patient safe and healthy.
If I may interject something here. So I think it's risk and benefit, right? We heard that with gastric bypass and advanced liver disease, you have substantial risks there. I agree with balloons. I mean, there's lower risk, but if there's no benefit, it's also not worth doing it, right? So ESG, however, does have very solid data for 5-year outcomes and maintaining a 15% total weight loss. So that's great. And now if you combine, and Dr. Sharaya's data is really one of the best there. Now, if you combine that with medicines, we might be able to really get a long runway with this while minimizing risk. So I think that we should not say surgery is the only answer here. I think we have to look at endoscopy as a very good solution for many of these patients because it allows us to limit risk and does get us stably above that 10%, but it's not balloons or necessarily some of the other therapies. The other thing that is interesting is duodenal mucosal resurfacing. Now, this gets back to something Francesco Rubino was talking about. We do not see 10% total weight loss with that at all, not remotely, right? But they were getting really impressive results with reversal of liver fibrosis and fat improvement. So something very interesting there is another mechanism of action unrelated to weight loss. So I think we have a lot of learning to do. And I do think there's, surgery is certainly a wonderful option for many of these patients. But I do think we also have to be very open-minded about these endoscopic alternatives.
Great. If I may just make an intervention here, it's important to notice that liver disease is not the only thing that occurs in these patients. These are very obese patients. They usually have diabetes, they usually have hypertension, they usually have a lot of other diseases that I'm an endoscopist. I really believe it's a new method and it's coming for something different in the future. But for now, for these patients that there are a complex unity of diseases, I still think surgery is the best solution for these patients because we can see not improvement only in liver fibrosis, but in the rest of the comorbidities.
Yeah, I think we may not agree on the answer here, or we would just have a long, lengthy debate, but I'm glad and the risks and benefits of each type of procedure. Sylvia, there's a question for you from the audience. What do you comment on the keto diet for obesity and for diabetes? And if you suggest the keto diet, how long do you suggest patients to be on it?
As a strategy for preoperative weight loss, we used to use more very low calorie diets. That's Dr. Kim used it, Optifast, that has a right content of carbohydrates, protein, and lipids. Keto diet can be used in general population like obesity. My concern is with the adherence of a keto diet for a long term. So maybe for 3 to 6 months, it can be a strategy. Or if you have a patient that is losing weight and you need to change the strategy, sometimes keto diet should be a strategy. However, as it doesn't have a lot of carbohydrates or nothing of carbohydrates, the adherence is a challenge. So maybe listen to your patient, and knowing the adherence and the weight loss is a good way to know if it is going to be effective.
Thank you. And do you recommend the Optifast diet for everyone pre-op, or is this something that you would also recommend for people sort of after surgery they've had, or after endoscopy, they've had a little bit of weight gain in order to maintain their weight loss?
Optifast is a commercial brand of a liquid diet. And I have studied a liquid diet before surgery, and it's a good strategy if you use like from 2 to 12 weeks. However, 12 weeks I think is like too long. 2 weeks is enough because most of the weight patients lose in the first 2 weeks. And the adherence is better than when they eat normal food because there is less options, and it is easier to measure a cup of whey protein or a plate of a soup. And when you use a brand such as Optifast or whatever, you know the content it is easy to know the content of the food. So I think it is a good strategy when you want rapid weight loss and with a security like before surgery, you need to improve the nutritional issues. You should promote good wound healing. So I think it is a good strategy. Here in Brazil, we don't have this brand available, but we have other brands, and you can do a liquid diet even with real food like soups, whey protein, and yogurts, and things like that.
I have a question for Kazu. If in the Asian population, we know that obesity, lower rate of obesity is associated with the comorbidities of the metabolic disorders. Do you find that fatty liver disease is also more prevalent at a lower BMI in the Asian population?
Yes, that's true. So from the viewpoint of Asian Pacific chapter, I'd like to emphasize that NASH, the biopsy-proven NASH, is much higher in Asian population. Like my series of biopsy, 74% of my patients BMI over 35 had NASH. Also in Taiwan, 72% of the patient, the bariatric patient, had NASH. But in Australia, just around 30 to 40% of the bariatric patient have NASH proven by biopsy. So that the Asian population has much higher risk of NAFLD. And recently, Asian Pacific Association of the Study of Liver Diseases just published their clinical guideline for NASH. They tried to change the name from NAFLD to MAFLD, metabolic disorder associated liver diseases. So that, and also they made a guideline to indicate the bariatric surgery for BMI over 35 with NASH, with MAFLD. And also for Asian population, BMI over 30 with MAFLD should be considered bariatric surgery. So that in the Asian Pacific region, the view is a little bit changing now. And also that the important thing is follow-up of the Ken Loy's patient, because I also have the same kind of patient, and he lose more than 35 kilogram, and also all kind of comorbidity resolved. And also the CT scan revealed that NASH and the NAFLD had a resolution at 2 years after surgery. But he developed HCC at 7 years after surgery, because the patient still have some fibrosis after surgery. So that such kind of patient must have some kind of follow-up, like sonography every year or something like that. That's my point of view.
Thank you. From the attendees, there's a question for Chris Thompson. Is there any experience about combining intragastric balloons and ESG for better weight control?
Yeah, not so far. That would be a sequential thing that would have to be done. We know that balloons are contraindicated in any stomach that has had any type of surgery, whether it's anti-reflux surgery, prior bariatric surgery, et cetera. So it's important not to do them, in close proximity. And I would probably say you would start with a balloon and then sequentially follow that with an ESG in planning a study. But I'm not aware of any data using that approach yet. More likely, you're going to see combinations of ESG with a small bowel procedure, such as an ESG with mucosal resurfacing or ESG with a endobarrier type device, or maybe a magnetic anastomosis. Or medications, right? Semaglutide, that'd be a really great combination that Vivek Kambari had studied a little bit with some Brazilian colleagues that seemed very compelling.
So I think with the diagnosis of a fatty liver or NASH or NAFLD, liver biopsies is still considered the gold standard. But as surgeons, we don't always do a liver biopsy. I like the opinion of the other surgeons. Do they do liver biopsies regularly or only when they're asked by the hepatologist or the gastroenterologist?
Yeah, this is Samer. And in the early phases of my career, I used to routinely do liver biopsies on all our patients. In fact, all my partners did as well. And then we found that the information that we had from these biopsies really didn't inform us in the course of the patient or its prognosis. So we stopped doing them unless it was indicated or in specially selected patients. But now that I'm, my interest in this disease is rising again, I think I will go back to routinely doing liver biopsies. It takes only, you use the TrueCut needle, it takes only 5 minutes. And although it's not a totally benign procedure, it is rather safe as long as you do it properly. So the answer is, I'm going to go back to doing routine liver biopsies, yes.
How about you, Gerhard Prager?
I do it routinely in all my patients, I think, for the last 10 years. And I find it very useful.
Citano?
Well, here we have to, talk to the insurance payers about what we are going to do prior to surgery. So we have to justify the motive. So no, we don't do it routinely. But when I get any visual intraoperative modification of the liver, I do the biopsy because I cannot get out without getting the diagnosis I need. So then I justify what I'm doing to the payers. This is the only problem. And some exams we do, and a lot of things we are talking about preoperatively. I know there's a lot of countries that the insurance payers, they do not pay for these exams. They do not, they require a lot of paper doing, and usually they do not let us to do these exams, including endoscopy. Chris, I know here in Brazil we do it routinely, but I know there's a lot of countries that it's not justifiable for the payer. So this is important also to talk to who's listening to us, that we have to go for what we have on our hands.
Lydia, just a comment?
Yes, definitely.
I'm more than happy listening that you are doing or planning to do routinely, because as we learned from the biochemistry, that ALT/AST, normal ALT/AST is very common in patients with NAFLD, and we need to use non-invasive tests like FIB-4, etc. When you are looking at the surface of the liver, it's much better to have a liver biopsy, because many times you can find a future that you are not can anticipate when you are doing the surgery, And I think it's very important to stratify and to quantify exactly what is happening in the liver to improve the management of this patient. And at this time, liver biopsy is crucial because, as we discussed before, non-invasive tests like FibroScan, the XL probe, they are not enough diagnosis accuracy for the decision making, and we need to combine. For sure, we need to develop an algorithm, a diagnostic algorithm, to be absolutely confident with the stage of fibrosis and the presence of steatohepatitis. But in the meantime, we need to use the liver biopsy of gold standard, and surgery is a fantastic moment to have this information.
What about Japan, Kazu? Do you do liver biopsies?
I used to do a liver biopsy in a clinical study setting, but recently I don't. Actually, that it's very rare to have a chance of a second biopsy for the patient after bariatric surgery, so that we couldn't reveal that the improvement of liver disease by second biopsy. But yeah, as many here suggest that it's very useful to do a routine biopsy, so that we will talk with our colleague to do that.
Okay, Reem, have you got any other questions to ask our panel?
No, I was going to ask the same thing to Chris, if he routinely does either FibroScan or liver biopsies, or we're more increasingly doing so because of the availability of portal hypertension testing now endoscopically.
Yes, we'll do a FibroScan on all patients, revisions or primaries, and then depending on what we see on the FibroScan, we will do an endoscopic ultrasound with liver biopsy and portal pressure measurements. And I think it's very nice to do. We don't do that as part of the actual weight loss procedure. We do that in advance. That way we're catching some people with portal hypertension, and we can address that with beta blockers and proper preparation before our procedure.
If I may mention something, please. one thing I'd like to suggest or even recommend to the group and other clinicians is what we've done here at our institution in Baylor. We've actually started a fatty liver clinic. And it's a clinic where patients who have fatty liver disease, many of them are obese. We approach them in a multidisciplinary fashion with the hepatologist. We actually have designed a special educational seminar for these patients. And we work together to both evaluate, optimize, and then treat these patients. And the beauty of it is that they continue to be followed in this specialized clinic. And with the rising number of these cases, I think there's a lot of benefit in that, but just a suggestion for the group.
I totally agree.
We do the same thing. I think that's sort of the future, are these multidisciplinary clinics between all prongs of what we see here in the case presentation, all disciplines to be part of it.
Hello, everyone, and welcome back to our session 2. We are going to launch our second case presentation. So this case will be presented by Dr. Abdulrahman Nimari from the USA. He's the Associate Professor and Chief of Bariatric Surgery of the Carolinas Medical Center. He's the Secretary and Treasurer of IFSO and founding President of the Middle East and North African chapter of IFSO. So welcome, Abdulrahman. Following the case presentation, we will also have comments from, firstly, Dr. Estuardo Behrens from Guatemala. He's the past president of the Guatemalan Association of Surgery. He's the past president of the Guatemalan Society for Bariatric and Metabolic Surgery, and the current president of the Latin American chapter of IFSO. Welcome, Estuardo.
Thank you for
Next
having me.
we welcome. Next, we have Dr. Bahram Abudaya from the USA. He's the Associate Professor of Medicine, Director of Advanced Endoscopy, Director of Metabolic and Bariatric Endoscopy at the Mayo Clinic in Rochester. He's a recipient of multiple awards and grants in support of his research, including the Star of Science Award awarded to him by His Majesty King Abdullah II during the World Science Forum in the Dead Sea in Jordan 2017. It's a pleasure to have you, Bahram. Next, we have Dr. Shelby Sullivan from the USA. She's the Director and Gastroenterology Metabolic and Bariatric Program at the University of Colorado at the School of Medicine. Welcome, Shelby. Last but not least, we have Dr. Mary O'Kane from the United Kingdom. She's a dietitian and she's the chair of the IFSO Integrated Health Committee. Mary led the development of the British Obesity Metabolic Surgery Society, BOMS, and the nutritional guidelines for the UK for the follow-up guidelines for patients undergoing bariatric surgery. Welcome, Mary. I'll now invite my co-moderator, Reem, to launch the poll.
Hello, everyone, and thank you, Lillian. So we're going to launch the second poll for this session. How do you evaluate a patient with GERD dysphagia and class 1 obesity and type 2 diabetes? First, an endoscopy and upper GI barium study, endoscopy and esophageal manometry, upper GI barium study and CT scan of the abdomen, history and physical examination is sufficient, or finally, evaluation by a bariatric surgeon. Please vote using the dashboard on the right of your screen. So while we're waiting for the attendees to answer, I'd like to ask Abdul Rahman to comment on this poll and what you think.
Sure, thank you, Reem, and I want to thank IFSO and WGO for the invitation. I think what's important to note about reflux is that the disease is a disease where symptoms don't necessarily correlate with objective findings. So when someone has heartburn, you might want to do an endoscopic evaluation, and if it shows significant reflux like Barrett's or LAC or D esophagitis, maybe those patients, you don't need to do anything else. But especially in patients who are considering to have procedures like sleeve gastrectomy in our field, someone has reflux symptoms and they just have not much on the endoscopy or grade A esophagitis, they might need real objective testing, maybe with a pH study. And the second important thing is, when someone says they have dysphagia, I mean, that is just a very broad term, and you need to really dig deep into that term and make sure whether this dysphagia is something recent, whether it's to liquids or solids, and maybe start first with just getting an X-ray test.
Okay, and we have the results. Would you care to comment a little bit on the results before we start the case presentation?
Sure. I think I'm very pleased to see that evaluation by a bariatric surgeon is not the first thing for this patient, or that history and physical is sufficient, because truly, or getting a CAT scan. I think the audience is right on the money, and I think both options have an endoscopy, which is reasonable. Getting a barium study first or proceeding right away from manometry will depend on the symptoms and dysphagia, and both of them are appropriate answers. So I think the audience is on the money.
Okay, well, thank you. And I'm going to invite Dr. Abdul Rahman Nimari to present his case.
Good morning. It is my pleasure and privilege to participate in the combined World GI Organization and International Federation for Surgery of Obesity webinar. My name is Abdul Rahman Nimari. I am an associate professor and section chief of bariatric surgery at Atrium Health, and have the privilege of and pleasure of being the IFSO Secretary Treasurer. It is my honor today to be with you to present a case about reflux, class 1 obesity, and type 2 diabetes. This is my disclosure slide. It has no bearing on the presentation. You can see my procedure disclosure as well as financial disclosure at the top. So our patient GRD is a very pleasant 43-year-old female who's been having significant reflux. She also lately had dysphagia. She's had reflux for 10 years, daily heartburn, regurgitation, and cough at night. She takes PPIs and lately noticed dysphagia to solids. She's tried numerous times to lose weight, and whenever she loses weight, her reflux improves, but then she would regain the weight back. She has class 1 obesity, BMI 34 kilogram per meter squared. She's been diabetic for 7 years on insulin, as well as metformin and glipizide. Her latest A1C is 9.5%, and her diabetes has not been well controlled. High blood pressure on 2 medications and hyperlipidemia on a statin. She smokes a pack per day for the past 15 years and would quit off and on, and her examination is largely unremarkable. Our endoscopy shows, as the picture depicts, a 3-centimeter hiatal hernia, grade B esophagitis without Barrett's, and she was H. pylori positive. She had a 48-hour Bravo capsule study that showed that on both days she has at least 125 episodes of reflux. The percent of the time where the pH was low was 8% on the first day, 12% on the second day, mostly in the supine position. She has a Demeester score of 48. Her manometry showed no motility disorders and the presence of a hiatal hernia. The patient is interested in a management strategy that minimizes the risk while addresses her reflux, dysphagia, her weight issue, as well as her diabetes. She's motivated to make a change, and she's more concerned about not only reflux, but the fact that her diabetes is uncontrolled, as she was told this could affect her quality of life. The patient is most interested in endoscopic options. She heard about a procedure called STRATA. She wants to hear more about it, as well as laparoscopic options that have lower risk. So she's heard about a procedure called LINX. She also wants to hear about it. When it comes to other procedures, she wants to know if having a fundoplication would help her reflux and if that's the best procedure for her. And she's very concerned about the options of metabolic and bariatric surgery, especially Roux-en-Y gastric bypass, as she heard many complications with that surgical option. If there is any surgery that would help her weight, her consideration would be to have a sleeve gastrectomy. Again, I would like to thank the World GI Organization and IFSO for the opportunity to participate in this webinar. Thank you.
Thank you, Abdulrahman. A very interesting case. I'm going to invite our first speaker as a surgeon to comment on your case, Dr. Estuardo Behrens.
Good afternoon, good morning, good evening. My name is Estuardo Behrens, and I am the actual president of Latin American chapter of IFSO. Thank you for the invitation to participate in this webinar of the World Gastroenterology Organization, together with the International Federation of Societies of Obesity Surgery. Dr. Nimeri has presented us a very interesting case. These are my disclosures. I have nothing to disclose. I do not have any conflict of interest. My case makes disclosure. In the last 21 years, I'm doing bariatric and metabolic surgery, 3,841 cases in the last 21 years. This is a very interesting case of a young female patient, 43 years old, who has a metabolic syndrome, florid metabolic syndrome, with obesity class 1, type 2 diabetes treated with insulin and 2 drugs, hypertension with 2 drugs, and hyperlipidemia with statins. A very heavy smoker patient, 20 cigarettes per day. And she's complaining of an important gastroesophageal reflux disease and hiatal hernia. The patient wants a relief. She's very well motivated to have a new life. The workup performed in this patient showed us that an upper GI endoscopy, she has a very important hiatal hernia, 30 centimeters wide. Achalasia was ruled out, no motility disorder, and H. pylori positive in this case. What are the alternatives? Well, we have to discuss this very well with the patient because she has a relief of the esophageal reflux, of the diabetes, hypertension, and the other comorbidities. The best alternative in this case is a Roux-en-Y gastric bypass plus closure of the hiatal hernia. If we perform a sleeve gastrectomy, the patient is going to have more reflux. We will discuss that later. The Stretta procedure is non-recommendable because it does not give any weight loss. The LINX is not recommendable because the patient is going to have only a poor weight loss. And the gastric mesenchymal fundoplication is a very well performed procedure in this kind of patients with GERD, but the type 2 diabetes and the other comorbidities had to continue in medical treatment, and it shows only poor weight loss. So the best alternative in this case must be a Roux-en-Y gastric bypass, laparoscopically performed with a closure of hiatal hernia. You can see in the picture a wide hiatal hernia, and in the picture on the right, you can see the closure of the hiatal hernia. And this is the end result. You can see the gastroduodenostomy performed, and this is going to relieve the reflux. We're going to close the hernia. The patient is going to have a very good weight loss, and the type 2 diabetes and hypertension, hyperlipidemia are going to remit and control. So the patient is going to have a very quality of life. So the best alternative, as I said, is the Roux-en-Y gastric bypass. All the time we have to think first in our patients. So the principle of primum non nocere, first do not harm, must prevail. The sleeve gastrectomy is going to produce more gastroesophageal reflux disease, albeit the control of metabolic syndrome, and in the near future, the patient has to have a Roux-en-Y gastric bypass. She's going to be converted. The endoscopic procedures are not going to control the metabolic syndrome, so they're not useful in this kind of patient. The mesenchymal fundoplication will control the GERD, but not the metabolic syndrome. So in these cases, we have to discuss with the patient very well, what does she want? If she wants the comorbidities resolved, so the gastric bypass is the best procedure performed in these patients. So thank you very much to the World Gastroenterology Association and IFSO to give me the opportunity to comment this case. We'll discuss this case with the other professionals. Thank you very much. God bless.
Thank you very much. And I'd like to ask Professor Barham Abu-Dayyeh to talk to us about his point of view.
Dear colleagues, my name is Barham Abu-Dayyeh, and it's my pleasure to present the endoscopy perspective on the case presented by Dr. Al-Numeri. These are my disclosures. It's very important to highlight the salient features of this case. We have a patient, a young patient with predominantly representation of pathological reflux in the setting of a 3 centimeter hiatal hernia and esophagitis. She has a dysphagia, she's a smoker, and she's worried about the risk of any intervention. Her obesity is mild and she has advanced diabetes. I don't think the current state of the literature offers clear guidance about the most optimal approach for such a patient because of the complex presentation. In that setting, it's important to weigh the risks and benefits of each intervention and use the principle that the best interest of the patient is the only interest to be considered. With that, it's very important to highlight that her predominant presentation is reflux, and reflux is an interplay between esophageal physiology, gastric accommodation and emptying, and the anti-reflux barrier made by the diaphragmatic hiatus and the lower esophageal sphincter. It's not a hypersecretory disorder, thus just addressing parietal cell is not sufficient to address this disease. So the gastric bypass is definitely a reasonable option in this case, but it's very important to weigh the risks and benefits if we're going to embark on a gastric bypass versus a minimally invasive approach to her presentation. So the first question in that quest is to answer, is Roux-en-Y gastric bypass truly an anti-reflux procedure and the holy grail for GERD? And there's some evidence to suggest that it's a good procedure to decrease acidic reflux, but it's not necessarily improve volume reflux of weakly acidic or alkaline refluxate. This is a cross-sectional study of about 870 patients about 256 underwent a row-wide gastric bypass and had endoscopy a few years after the procedure. And you could see that the acid reflux or presence of esophagitis was present in about a third of the cohort, and that's heavily confounded by the presence of a hiatal hernia. So this is also a corroborating evidence from a nationwide cohort study that looked at adults with preoperative reflux who underwent gastric bypass. And they looked at remaining or recurrent reflux more than 6 months after surgery. This is from Sweden. And they showed that about 50% of the cohort continued to have reflux or had recurrent symptoms requiring medication that remained stable up to 10 years after the procedure. So the issue is when you look at objective physiological measures of manometry and pH, that the row-wide gastric bypass does improve acid exposure time, but it does not significantly alter the total reflux episode, especially of alkaline or weakly acidic refluxate, as shown in this meta-analysis. And actually, the accommodation of the pouch might be problematic, especially in the setting of a hiatal hernia. This is a patient subjected to endoflip functional planimetry, and you could see that the gastric pouch is not very compliant, and there's a hiatal hernia present that with a non-compliant pouch, the force of the contractility is in a retrograde fashion to the esophagus, conducive to significant reflux in that setting. So if the risks benefit of gastric bypass are not sufficient in this case, what alternative I could give you from an endoscopic perspective? And I would argue that a combination of a proper anti-reflux procedure, which is a hiatal hernia repair, plus fundoplication and a minimally invasive endoscopic sleeve gastroplasty would be a better option. This is a very similar case to the one presented at the Mayo Clinic with a small hiatal hernia, about 3 to 5 centimeters, that we corroborated with our surgical colleagues in order to repair the hiatal defect laparoscopically and offered either a transoral fundoplication or a partial toupet fundoplication combined with an endoscopic sleeve gastroplasty, which is anatomy preserving. The advantages of the endoscopic sleeve gastroplasty, as shown in this functional MRI, is it does not affect the motility, the innervation of the stomach. Thus, the motility is intact. There's no dissection of the ligament, suspending the stomach with a remaining accommodating small fundus, which also is not conducive to be a high pressure zone for reflux. You could see 9 months after the procedure, the patient has normalization of her Demeestry score and a significant weight loss with a change in BMI from 46 to 29. But you might tell me, wait a minute, Dr. Abudeya, you forgot about the elephant in the room, and the elephant in the room here is poorly controlled diabetes mellitus, and for that, I would refer you to an important study published in the New England Journal of Medicine, and subject to you that the weight loss observed with the combination of hiatal hernia repair and endoscopic sleeve gastroplasty with a fundoplication is sufficient to have improvement or remission of type 2 diabetes. Again, with this New England Journal of Study, they subjected 15 patients to gastric bypass, matched them to cohort that underwent low caloric diet and achieved the same exact 18% total body weight loss. They did a battery of sophisticated testing, including a hyperinsulinemic, euglycemic pancreatic clamp that showed identical improvement in both groups. And when they looked at 24 hours glucose profile, 24 hours insulin profile, beta cell function, and body composition, all were equivalent as long as the weight loss was significant, and in that case, more than 18% total body weight loss. And with that, I conclude and thank you for your kind attention.
Thank you so much. And next we have Dr. Shelby Sullivan, and we'll hear her presentation. Thank you.
Hi, my name is Dr. Shelby Sullivan, and I'm going to be discussing this case today. And I'd first like to thank the organizers for inviting me to discuss this case that we'll be talking about, including a patient with class 1 obesity, GERD, and type 2 diabetes. These are my disclosures. I've been involved in a number of research studies on endoscopic bariatric therapies, and I consult for a number of endoscopic bariatric therapy companies. So there are several issues with the patient that was presented today in this section. And that includes the BMI of the patient. She has a BMI of 34, which in the United States would preclude her from getting insurance coverage from many insurance carriers for a bariatric surgical procedure. The next issue with this patient is that she has GERD that's uncontrolled on a PPI, and she also has a significant hiatal hernia of 3 centimeters. This also affects what kind of therapies we would be willing to do and what kind of surgeries we'd be willing to do for this patient. She's also a smoker, so that puts her at risk for surgeries, but also puts her at risk for cardiovascular disease as well. Her diabetes is not currently at goal, and she's also not on medications that would be recommended as second-line treatments in the American Diabetes Association treatment algorithms for the treatment of diabetes. And this is an important point. We're going to go over that right here. So this is a very busy slide, but essentially this goes over the algorithm that the American Diabetes Association recommends for the treatment of patients with diabetes. The first-line therapy for any patient with diabetes in America, the recommendation is to start off with metformin. The next therapies, though, really depend on patient characteristics. And we're going to talk about this in this next box that I've highlighted here in a little bit more detail. So the next step is really to decide to determine whether or not the patient has risks for cardiovascular disease or currently has cardiovascular disease, chronic kidney disease, or heart failure. And if that is the case, in particular with cardiovascular disease, the next therapies that you would want to consider as the second-line medications would include either a GLP-1 receptor agonist or an SGLT2 inhibitor. So they both have indications for lowering cardiovascular risk. And in this patient who has diabetes, a class 1 obesity, has a history of smoking, has hyperlipidemia and hypertension, that patient is at high risk for cardiovascular disease. It's also most likely, based on all of these characteristics, that she likely has non-alcoholic fatty liver disease as well, which again is putting her at a higher risk category for cardiovascular disease. These medications have data with lowering risk of cardiovascular disease, and in particular, GLP-1 receptor agonists also have benefit not only for diabetes, but also for patients who have non-alcoholic fatty liver disease as well. In addition to that, both of these medications have weight loss benefits, the highest weight loss benefit being with semaglutide. So then when we really think about the options for this patient and how I would think about this patient in my clinical practice, first and foremost, regardless of what therapy you were doing, you would want to have this patient quit smoking. And one of the things you can add to help with the patient smoking cessation is bupropion, which does have an indication specifically for smoking cessation and can also help with weight loss as well. So the next thing I would do is have shared medical decision-making with the patient. And the first thing I would discuss is whether or not the patient would accept a surgery or a procedure. If the answer to that is no, then we go with really intensifying both medications and lifestyle therapy. And I would talk to the patient and try to get the patient on a GLP-1 receptor agonist, specifically semaglutide. This would have to be done in conjunction with the patient's either endocrinologist or their primary care physician, because their insulin does need to be adjusted and decreased while they're starting this GLP-1 receptor agonist, because it will lower their need for insulin. I would also intensify their lifestyle therapy. This is both to help for weight loss and also to change behaviors that may be worsening reflux. And then we would make sure the patient is on high-dose PPI therapy and Carafate. If the patient is willing to undergo a surgery or a procedure, I would first talk to the patient about gastric bypass. Now, again, in the United States, this is likely not going to be covered by insurance because her BMI is less than 35, but we could still discuss the option and also consider whether or not the patient may be able to pay out of pocket. And this is different for other countries. In addition to that, I would still discuss whether or not the patient may benefit from a GLP-1 receptor agonist. The other option is that the patient could undergo an anti-reflux surgery that would help with reflux and to treat her hiatal hernia, and could also undergo an endoscopic bariatric therapy, specifically an endoscopic sleeve gastroplasty or the Aspire Assist system. In this patient, I would not proceed with an intragastric balloon because that could worsen her reflux. And if she did undergo an anti-reflux surgery in her foregut, that would be a complete contraindication to getting an intragastric balloon. In conjunction with those therapies, I would again also think about adding a GLP-1 receptor agonist, specifically semaglutide, to help treat her diabetes, lower her cardiovascular risk, and again, if she has non-alcoholic fatty liver disease, which she likely does, would also help with that as well. Thank you.
Thank you, Shelby. Last but not least, let's hear from Mary O'Kane, the wise words of a dietitian. Mary.
Thank you, Dr. Namiri, for this case presentation. And it's a real pleasure to be taking part in this webinar today. These are my disclosures. So as a dietitian, I'm interested in the whole person and I want to know more about the social history. The weight history of this patient is already known and she's had many past attempts at trying to lose weight. And I'm also very interested in her current dietary intake and her eating patterns and how this fit into her typical day. I'm concerned that she has dysphagia and I would be looking at the quality of her diet and also requesting nutritional bloods to make sure she hasn't got any nutritional deficiencies. I would like to know whether or not she has a history of eating disorders. And then when we're looking at the options, we're looking at intensive lifestyle interventions with or without anti-obesity medications and also bariatric and metabolic surgery. So there's many recommendations about what people should do with obesity and type 2 diabetes. And these Canadian guidelines highlight the fact that lifestyle interventions where people can lose 7 to 15% of the total initial weight loss will help to improve diabetes control and help resolve some of those other comorbidities. There's lots of evidence pointing towards this, and I'm just going to talk about two studies, which is the Look Ahead and the Direct study. And both of these had patients with overweight and obesity and type 2 diabetes. In the Look Ahead study, those who received the intervention, because this is a randomized control trial, had structured meal plans and meal replacements over the year, and then years 2 to 8 focused on weight maintenance. And what they found was that those who achieved 7% weight loss had improved glycemic control. The Direct study is also an RCT, and in this, for the first 12 to 20 weeks, those receiving the intervention had low-calorie liquid meal replacements, and these were just over 800 calories a day. This was then supported with food reintroduction and a focus on weight maintenance. And what they found that a year, that if people had managed to, that 46% of participants had managed to achieve diabetes remission at a year, and 36% at 2 years. And those who lost 10 kilograms had good outcomes, and those who lost 15 kilograms had even better outcomes. However, one must remember in this study is that people had type 2 diabetes for less than 6 years and were not yet on insulin. So there's evidence pointing to the fact that if people have interventions early when they've had the recent onset diabetes and are not yet on insulin, there's a greater chance of people having diabetes remission. But obviously Our Lady has had diabetes for some time and is already on insulin. Also, a number of guidelines recognise that early intervention, again with recent onset diabetes and also with class 1 obesity, is more likely to achieve better outcomes. And the Canadian guidelines, like others, recommend that bariatric surgery should be considered if people are not optimally managed with medical treatments. And in this study, the Stampede study looked at intensive medical treatment, which would have included anti-obesity medications versus bariatric surgery in people with type 2 diabetes and obesity, and there's a 5-year follow-up. So for me, what's interesting in this study is it's a mean duration of diabetes for 8 years, and that 36% of those going forward for surgery have class 1 obesity. And what they find is that 5 years, that those who go forward for surgery have a greater weight loss, they have better diabetes control, and there's a reduction in medications, including insulin. So this is definitely an option for this patient. However, it's not just about the weight loss, it's also about weight maintenance and avoiding weight regain. And I just mentioned the SOS study, and this is not a randomized controlled trial. It's where people went either down the surgical arm for weight loss or medical treatment, which should include obviously lifestyle interventions. And what you can see in the left-hand graph is the 20-year outcomes, and it shows that those who go forward for bariatric surgery are likely to have a lower weight at 20 years than those who went down the medical intervention group. But we must remember that this is not a randomized control trial. People were lost to follow-up, and even with the surgical group, there can be some intense weight regain. When we look at the ones who went in the medical group in the right-hand graph, you can see that after 2 years, many people will regain weight, and for some it will be significant. However, I want to just highlight that at 10 years, that there were a number of people who were still managing to achieve those clinically significant weight losses. So what's the best for this patient? I think it's really important that we discuss options, and this could include the intensive lifestyle interventions with or without the anti-obesity medications. Another option obviously is the bariatric and metabolic surgery. And as a dietitian, what I want to do is present objective information to this patient, empowering her to make an informed decision as to what is best for her at that time. So thank you for your time, and I look forward to the panel discussion.
Thank you very much, Mary. Well, we're going to open this for discussion with the panelists as well as the speakers. I'll also like to remind our attendees that they can actually send in their questions, and we'll try and answer those questions as well. My first question is to our panelist, Gerhard Prager. We heard that this patient does not qualify for metabolic or bariatric surgery in the USA. Would this patient qualify for surgery in Austria and in Europe?
In Europe, we have a very different situations. We have very strong public healthcare systems. At the moment in Austria, she will not have coverage from the public healthcare insurance. Saying that in Switzerland, she would have coverage. So you have very different situations. I would try to fight for this patient for coverage. So you can get an individual solution. So I'm very confident that even in Austria, although it's not covered on average, you would get coverage for this patient. I think this would be a very nice case of real metabolic surgery, as the weight loss is not in the focus. But with the uncontrolled diabetes and reflux, I would totally agree that Roux-en-Y gastric bypass is the way to go, for me at least, at this patient.
Are you concerned about her smoking history?
Definitely. I think this is something we have to consider. She must quit smoking before having surgery, or at least that's what I would stress on. And of course, from a surgical point of view, you can play around with the size and length of your pouch. The more stomach you have in the food stream, the higher the risk for anastomotic ulcer will be.
Eamon, I'd like to follow up by asking you, do you think there's any undiagnosed motility disorders in these patients? Should they undergo manometry routinely, even though it's sort of not standard of care at the moment, unless they have any symptoms? So, because sometimes we've seen patients with bariatric surgery sort of 5-10 years out who present with things like achalasia.
Achalasia would be my only worry, and that can be actually screened for maybe more simply by doing a timed barium study. Not easy to get in a lot of places. But there's one other point I wanted to bring up, and that we seem to have forgotten. This patient was Helicobacter pylori positive, as far as I remember, correct?
Yeah.
Yes.
So we're talking about a patient who's got a precancerous condition of her stomach, and we're talking about excluding the stomach. So what comments do the surgeons have to make about this?
So I would, of course, eradicate these patients. We do endoscopy in all our patients preoperatively. And if we have H. pylori positive patients, we do eradicate them. That's our strategy.
I do agree.
But it wasn't mentioned.
That is true, but even for any of the endoscopic procedures as well, I always check H. pylori before any endoscopic procedure, any endoscopic bariatric therapy.
I just want to mention that after sleeve gastrectomy, we've just published a few weeks ago our 15 years data, and we also published our 10 years data. And after 10 years, this is a real refluxogenic operation. And I have no idea why an endoscopic sleeve gastrectomy would be different in that part of the game.
And Barham can speak to this as well, but there has actually been a comparison. Vivek Kambari published a series comparing sleeve gastrectomy to endoscopic sleeve gastroplasty, and there's less reflux that occurs after endoscopic sleeve gastroplasty compared to sleeve gastrectomy. And part of the reason why, and Barham brought this up in his talk, is that you are leaving the top part, the fundus of the stomach, open. So you do have this essentially non-pressurized system at the very top of the stomach. And so that may contribute to the lower rates of reflux that we see after these patients. And from an anecdotal standpoint, clinically, most of my patients after endoscopic sleeve gastroplasty do not have reflux or do not develop reflux symptoms.
I agree with Dr. Sullivan, and I will add, we looked at this in the MERIT, which is the US multi-center randomized trial, which will come out soon, hopefully in IFSO, that reflux is not a major contributor to the endoscopic sleeve. So I think we've settled that issue, and now there's actually pH per data that will support that notion as well.
My concern is also the fading of efficacy with time, which we see in the sleeve gastrectomy, and I would also expect for the endoscopic sleeve gastrectomy. But this is just my personal concerns.
And that's a real concern, and that's why if I have to have a crystal ball and say what's the future is going to be you have two strategies. One is a strategy to lose the weight and put the disease into remission. And I say remission, not cure. There is no cure for this disease. And the second would be for weight maintenance with a multitude of tools that we have at our disposal now, including a lot of good medications. So I think the future is going to be as such with these combinations.
And I think the other thing that we need to keep in mind, and Barham just made a point on this, is that there is no perfect procedure. And especially for those of us, about a quarter of my population is actually patients who've regained weight after gastric bypass. So there's weight regain that can occur with any procedure. And I think that we need to be vigilant about it and develop management strategies for that.
But especially
if there's one comment I would make to support what Gerhard said, is that 5 years after sleeve gastrectomy, when surgeons were told that it might cause reflux, they said it doesn't. We did not figure out that it causes reflux and Barrett's except 10 years out, 12 years out, 13 years out.
If I may, I'm going to be a little controversial here, Abdurrahman. You know, this lady that you presented obviously has florid metabolic syndrome. But what worries me most about this patient, the characteristic of her smoking. She's a heavy smoker. And from a surgeon's point of view, who's treated these patients for over 20 years, the thing that scares me most, the thing that gets me up at night most often is marginal ulcers and their bleeding and their pain and their perforation. And I've learned over the years that heavy smokers are simply not going to quit. They're not going to quit smoking. Or if they do, they come back and start smoking again after surgery. And frankly, to me, that is a huge factor in my decision-making process. Now, we could give her a sleeve, we could fix the hiatus hernia at the right time, at the same time, and then who knows, the weight loss might reverse her GERD, her esophagitis, and then survey her for the occurrence of Barrett's. And frankly, I know I shouldn't be saying this, but the sleeve gastrectomy doesn't burn bridges. Worst case scenario, if her reflux returns or Barrett's develops, then you can convert her. The other important point is the lady came asking for a sleeve. And the other thing that I've learned over the years is you have to listen to the patient, because you could convince her to get the gastric bypass, but she's going to be always hostile about it. She's going to say, I did not want this operation. Just some thoughts to bear.
So Summer, you're going to give her sleeve gastrectomy and repair a hiatus hernia. Would you give a sleeve gastrectomy and the links?
Yeah, possibly a links, or maybe reserve the links to later, or reserve the strata to later. If I'd give the chance to see if the weight loss alone might improve her reflux. If it doesn't, you know, if you have a well-constructed sleeve and a patient who's losing weight, I think the chances are her GERD will reverse. Remember, as Barham very eloquently demonstrated, the Roux-en-Y gastric bypass is not the holy grail, as you said. At least 15 to 20% of patients with gastric bypass have reflux disease. So yeah, I would probably just fix the hernia and just reserve endoscopic procedures or the links should the symptoms recur.
One point I would add to this discussion is there's dysphagia as well. And I have to say there's an evolving, still premature, but evolving body of literature to suggest a new entity that's called POSIT, or post-obesity surgery esophageal dysfunction. It's a pattern that we still do not understand. It's characterized by dysphagia, characterized by absence of secondary peristalsis and ineffective esophageal motility. It's hypothetically due to increased afterload on the esophagus from years of exposure to high pressure zones. Still, we don't know if it's reversible or not, but this is something to keep in mind with these procedures for sure.
Can I ask about the links? Is the hiatal hernia not too big for a lynx?
In this case, it is.
And also, links could make her dysphagia worse, even though her manometry does not show motility disorder.
That's why I would just repair the hernia and then see what happens.
If I would make just one comment, I think Shelby Sullivan really is very astute at picking up that the patient is not on the best medical therapy. I mean, this patient has several things that need time with a dietitian, an obesity medicine specialist, time to treat H. pylori, get her on the right medication, and maybe in 6 months, she'll be a different patient.
I can tell you that, you know, one of the first things that I do when I see patients is first, what's going on with their current medications that they're on. I am not a diabetologist. I don't suggest that I am one, but I do try to follow the guidelines. And it is amazing what can happen when you get patients off of medications that are kind of contributing to their weight gain and onto medications that can cause weight loss. And in this patient, if she's a super responder to semaglutide, then you might get 15% total body weight loss even at the diabetes dose of semaglutide. That's not going to be the average, but some patients are going to get there with that. And then would you need to even go to a surgery, or you would still consider maybe an anti-reflux surgery at that point?
But I would be hesitant to do any refluxogenic operation in this patient because her Demeester score is exceedingly high. It's more in the supine position, which tells you she has proximal migration of the Z-line already. She has a hiatal hernia. And in a patient like this, I would be very hesitant to offer her anything that causes reflux. One thing we do in the US for someone like this is to approach the insurance company not as a weight loss operation, but to tell them this is a patient with documented reflux who needs surgical therapy, and show them the literature that a fundoplication has worse outcomes and a high recurrence rate long-term, and that the procedure we're doing is merely to treat reflux. And we've been very successful in convincing insurance companies to offer her, once she's ready, a Roux-en-Y gastric bypass at this BMI or even lower, if we prove that the #1 indication is not weight, it actually reflux.
And I think that might be region to region dependent too, because we have not had as much luck in Colorado with that.
Mary, there's a question for you. I mean, you eloquently showed the SOS study with weight regain, and we often see that with various different types of surgery, also with different types of endoscopy. So how do you help your patients achieve a targeted weight loss and maintain that weight loss? How often do you see them? What kind of diet do you recommend going long-term after they've finished their bariatric diet?
I think one of the first things I need to mention is that the long-term follow-up available to many patients isn't as long as it should be, because it should be lifelong. But certainly in that first year, there'd be intense dietetic support, helping the patient reintroduce foods, reintroduce textures, actually learn to eat the smaller portions, and actually gradually moving that person back towards 3 meals a day. And there's some interesting work that's been done by Dr. Mitchell and his colleagues, looking at the fact that if people can return to 3 meals a day, stop eating before they feel full, that they're more active, that they don't graze, they're going to have better outcomes. And this is saying from many studies as well. So it's about how that first year is more focused on the weight loss. The second year is on the weight maintenance. And then really what we need to be able to do is actually help people have that longer term follow-up. But in the UK, certainly in our health service, we're only able to give 2 years follow-up, and then we have to discharge back to primary care. And what I'd like to see that there is a model, even if people just have access to annual reviews and just that annual monitoring, so we can actually keep a check, because inevitably there can be weight gain as we age, but for some it can be more intense than others. And then I think it's already mentioned that the new medication that's coming online, which is not as available in the UK, that may also help that weight maintenance phase.
Thank you. And I know we focused a lot on GERD, but I want to sort of ask Professor Kasama, would you consider if the patient, let's say, didn't really have GERD and just the diabetes part, what would be the optimal surgery that you would offer her? We discussed this sort of in the first session, but I think with the case presentation, I want to hear the panel's opinion as well.
Yeah, I would like to offer her gastric bypass with hiatal hernia repair. So actually, that she had H. pylori positive, but if eradication works, it doesn't matter so much. So that the gastric bypass is the better option for her, even she had the hiatus hernia or not. So from the viewpoint of remission of type 2 diabetes, I think that the gastric bypass is good for her. And also the gastric bypass is good for her, the GERD, if she had hiatus hernia repair simultaneously. Also, she may have one of the biggest objective on gastric bypass is a smoker. If she can quit smoking, the gastric bypass is the best. But if she cannot, the sleeve gastrectomy is the second best option.
Thank you. Barham, do you routinely do EndoFlip on these patients? I saw, obviously, you did it in this patient who had GERD and dysphagia-like symptoms, but sort of going back to my question to Eamon, what about the undiagnosed manometric issues?
Yeah, Reem, so thank you, Dr. Sharha. It's an interesting phenomena that we recently report in the Red Journal, the American Journal of Gastroenterology, this entity of POSIT. Or post-esophageal surgery endoscopic dysfunction or esophageal dysfunction. And since then, we've been interested in seeing why this happens. Is it a chronicity issue? Is it a time-dependent phenomena? So on a study, we've been doing EndoFlip on obese matched cohort versus those undergoing bariatric surgery at different time points to try to elucidate some of the functional physiological changes that happen to the esophagus with time after the different iteration, whether it's obesity alone, endoscopic procedure, surgical procedures such as sleeve and Rowa gastric bypass. So I would say we've done it now. I think we have a cohort of close to 120 patients, and we're going to continue to do this to hopefully get more clarity on what's happening to the esophageal physiology with time after these operations, which is an important metric that we need to follow for sure.
Great, thank you. And I guess this also follows the second question from the audience. Also, you could probably answer, or any of the surgeons who do the combined TIF procedure. So what about the combined C-TIF followed by a surgical sleeve, not an endoscopic sleeve? I guess any of the surgeons, if you have experience, and I know Barham has some experience as well.
I haven't.
You do?
No.
Okay. Barham, then I guess the question goes to you again.
So yeah, I mean, that's the key is, again, if we go to the prism, the interest of the patient is the only interest, and we work as a team to take care of the patient, then you'll see this collaboration between surgery and endoscopy to achieve something that individually we cannot achieve together. So yes, we do collaborate with our thoracic surgeons a lot to offer these hiatal hernia repairs plus a toupee with an endoscopic weight loss options, especially for those with GERD and BMI above 35, because right now there's the only alternative is gastric bypass, as our colleagues stated. So these collaborative procedure happens a lot actually, and we will continue to push the limit with this collaboration. And I think the future is as such is we are one team taking care of a patient, and we should do it together with the best interest of the patient for sure.
Okay, great. Mary, this question's for you, but then I'll throw it out to the rest because I know I often get asked this as well. Do you recommend intermittent fasting as a way of weight maintenance or weight loss? And if so, for how long? And which type of intermittent fasting do you do? Is it this sort of the 2-5 or just the reducing the number of hours?
I think I'm always guided by the patient because different things work for different people, and there is no evidence as yet that one diet is superior to the other. So for some people, if intermittent fasting works for them, happy to work along with them, make sure that what they're doing is safe, that it's nutritious, that they can afford it and they can adhere to it. But equally, if they want to try some other way to lose weight, I'm quite happy to support that as well. But the recent reviews I've seen don't show that one way of trying to lose weight by diet is actually superior to another sort of diet.
Great, thank you. And Professor Prager, yeah.
If you present this case to 100 surgeons, we're going to have a lot of opinions, but most of them are going to say that this is going to be a gastric bypass procedure. And I have a question for the surgeons. The length of the limbs in this case, if a gastric bypass is done. Thank you.
I would, should I start? If I was if I was going to do a gastric bypass on the patient, the the roux limb would be at least 100 centimeters because she already has a tendency to have acid reflux. And so we want to prevent or minimize the chance that she might have a alkaline or bile reflux. With regards to the other limbs, you know, her BMI is 34, I believe. So dramatic weight loss is really not necessarily an objective here. So I would make sure that the BP limb was no more than certainly less than 1 meter, maybe 60, 70 centimeters long.
Gerhard? Yes, for me, we go for the elementary limb, a minimum of 70 centimeters, because this is the minimum length to prevent bile reflux. So I'm pretty in accordance with Samer. And for the BP limb, as short as possible, around 40, 50 centimeters. So I can just echo what you said.
Dr. Nimeri?
Yeah, I agree. 100 centimeter roux limb, 50 centimeter BP limb for the same reasons outlined by Samer and Gerhard.
Dr. Kazama?
Yeah, 50 centimeter of BP limb and 1 meter of the elementary limb, just like the other.
So we surgeons, we do agree that this case fits for a gastric bypass. Is that correct?
Let's hear from Lillian. I have not heard the limb length from Lillian.
No, I do agree. 50 and 100 is what I would do.
But the second question, we do surgeons do agree that this is case for a gastric bypass? I heard that Samer says that
I don't agree. I'm more concerned. I predict that I will have more problems with marginal ulcers than with reflux in this patient if I give her, you know, the chances of having reflux issues with the sleeve, I think, are going to be less than the chances of having smoking related complications, even in the face of maximum PPI prophylaxis.
So if I can make a comment, I think because she has objective evidence of reflux with very high Demeester score, I'd be hesitant to give her a sleeve. As I said, I think she deserves to spend some time with a dietitian and an obesity medicine specialist to better control her diabetes and maybe control her weight a little bit. But I do think marginal ulcer it will prove to become a technical complication, just like internal hernia. The size of the pouch we make affects the marginal ulcer significantly. We now have literature to show that H. pylori doesn't. Smoking does, so the time she'll spend with the obesity medicine specialist is also a time for me to understand her smoking behavior. But I would certainly spend time with the team and then Roux-en-Y gastric bypass.
I fully agree with Abdelrahman. I would not do a sleeve gastrectomy in a patient who suffers from GERD preoperatively.
So I'm going to end at this controversial note. I think the key answer here is to listen to our patients, understand their comorbidities and their habits, because that could interfere with any type of surgery that we choose. Thank you again to our panelists and speakers and my co-moderator for a great second session, and we'll be back after this break.